I wanted to do a video on cancer immunotherapy for a couple of reasons. One, because in the past several years, cancer immunotherapy kind of has um, become very popular and is becoming a very well utilized treatment regimen. And two, knowing the history of something helps us understand it a little bit better. And I found this pretty good article in Frontiers of Immunology about the history of cancer immunotherapy. So let's read it together. All right. So in the beginning, they kind of talk about smallpox. This is more about vaccines, which are kind of related to cancer immunotherapy, but not really cancer immunotherapy. So we'll kind of skip this section. I will probably do a video on the history of vaccines because I think that's also a very interesting topic. All right. So from ancient Egypt, some 3,000 years ago to the early 19th century, there's been multiple anecdotal reports of tumors disappearing spontaneously or after infection with concomitant high fever. Yeah, so there's been all these reports throughout history where people notice that if you get a tumor and cancer, if you get also an infection in the area and have a really high fever, sometimes the cancer seem to go away. And the Greek physician Galen, who's one of the fathers of modern medicine, Hippocrates was the other. Um, he noticed a similarity between cancer and inflammation. And in fact, in like inflamed tissue and cancer look very similar on both physical exam and radiography. It's hard to tell the difference, and only under a microscope can you tell the difference between inflammation and cancer. Grossly, they look very similar. So people have noticed this relationship between the two. And then there were attempts to modulate the immune system to cure cancer by two German physicians, and I can't say their name, who noticed that there was significant tumor regression after erysipelas infection. This is a type of skin, just a skin infection, basically. It's like cellulitis, but more superficial. And they try to repeat them, but they couldn't repeat their things. But they made a similar observation that with this specific kind of skin infection, they noticed that tumors tended to get smaller. Now, the person that's most closely identified with cancer immunotherapy is this guy named William Coley, who is known today as the father of immunotherapy. So what he did is he attempted to harness the immune system for treating bone cancer way back in the late 1800s. He noticed that some cancer patients went into spontaneous remission after developing this erysipelas or some other similar infection. And what he did is he um, he tried to um, inject people with different mixtures of the streptococcus and serratia into the patient's tumor. So he injected bacterial cultures directly into the tumors, and it it actually was successful quite a bit of the time. Let's see if it tells you. Uh, yeah, he achieved durable and complete remission in several types of malignancies, including sarcoma, lymphoma, testicular cancer, and reported over 1,000 regressions or completely cured patients. So, I mean, yeah, it was actually really successful in some patients, and in 1,000 patients, they had at least partial response. That would be considered a pretty good success. Um, but because people didn't know how this worked, and also it caused people to have really bad infections, and I think probably some people died from the actual bacterial infections. People kind of stopped using these Coley's toxins. These were available commercially into the early 1900s. So this was a thing that they did like over 100 years ago. Now the thing to know is that inflammation is not always good for cancer treatment. Sometimes inflammation makes cancers grow faster. So inflammation is a kind of a double-edged sword. You can cause inflammation, which will cause inflammatory cytokines that brings in the immune system into the cancer, and then the immune system will attack the cancer. Or you can have inflammatory cytokines that cause growth hormones that are used to propagate the immune cells that would fight off the tumor, but the cancer can feed on these growth hormones as well, and it can actually make cancers grow faster. So sometimes inflammation makes cancers um, be attacked by the immune system, and sometimes inflammation drives cancer growth. So it's kind of a double-edged sword, and we don't really fully understand why in some cases it works against the cancer, and in some cases it promotes the cancer growth. Okay, so then it was kind of forgotten for about 50 years until there was a lot of work starting in the mid 1900s on our understanding of how the immune system works. Like, we didn't really understand how the immune system worked until fairly recently. And then they discovered T cells, which are part of cellular immunity. And then they discovered dendritic cells, which are antigen presenting cells. So what these cells do is they will take up, like, for example, in this case, cancer cells, and they'll figure out what part of these cancer cells are different than regular cells and present them to the T cells so that they can recognize these things and say, okay, these cells are bad. We need to take care of them. And then there's these things called natural killer cells, which are part of our innate immunity. They don't have to be primed, but they can just kind of detect, hey, that something is not right about this cell, and then they can kill it and take care of it. So there's a lot of things that we learned about the immune system starting in the 1950s, and then later on they figured out bone marrow transplant for hematologic cancers like leukemia, and this is still used today. So we still do bone marrow transplants, and that is one of the things that can be a potential cure for certain types of leukemia, and I think lymphoma as well. Okay, so let's go on here. So then this talks about a very interesting thing that's used in bladder cancer. So urologists use this. There is this bacteria, the BCG, uh, which was used as a tuberculosis vaccine. And so this is still, I think, used in many parts of the world as a tuberculosis vaccine. And if you get this bacteria, it gives you some protection against tuberculosis. It also makes you test positive for the skin test if you get skin tested for tuberculosis. And that's a false positive test. But they realize that this bacteria, when you place it into the bladder, it can cause an inflammatory response that prevents recurrence of the cancer. And so this is a therapy that's been shown to be very effective, and it continues to be used today in non-muscle invasive bladder cancer. So if the bladder cancer is not that advanced and has not invaded the muscular layer of the bladder, it's just in the skin or the endothelium, they use this a bacteria to cause an inflammatory response, which kind of prevents cancer recurrence in that form of cancer. Okay, so this is an important concept where they talk about immunosurveillance. This theory of cancer immunosurveillance says that basically what the immune system does is the immune system is constantly looking at our body, and there are constantly cancers. According to this theory, we're constantly making cancers all the time, and there are mutations or other events that start a cancer, but the immune system catches it early and takes care of it and eliminates it very early before we even notice, before there's any symptoms or any tumor. And so there is this constant surveillance of our body where cancer cells that are springing up are being taken care of all the time by our immune system. This leads to the other kind of flip side of the coin, which is called immunoediting. And what that means is that the cancer cells, they learn how to evade the immune system, because the ones that can't evade the immune system are eliminated by the immune system. But the ones that become clinically relevant tumors are the ones that somehow are able to evade the immune system. And that is something that is not well understood as well. I mean, there's a lot of things that we know. There's like all these immunosuppression factors like fast ligand and regulatory T cells and myeloid-derived suppressor cells. So these things, the cancers can utilize them to kind of suppress the immune system around its own environment. There's other things that it does where it tries to decrease the amount of antigens that it shows on its surface, or there's these things called MHCs, which are these cell surface markers that all cells have that are needed to present antigens to the immune system. They can try to depress that. There's like hundreds of mechanisms that we've kind of discovered over the past several decades on how cancer cells are able to evade the immune system. So it's kind of it's an arms race. The immune system is trying to find the cancers and eliminate them, and the cancers are trying to find ways to hide from the immune system at the same time. So antibody-based therapies, these are the therapies that are the most commonly used today. And so most of these are monoclonal antibodies, and monoclonal means that they're just a single type. So they find one clone, one type of antibody, and then they can produce lots of it in a laboratory of this one type of antibody that's very specific and attaches to this very specific thing. So this is talking a little bit about the technology behind that. In the 1970s, Milstein and Kohler pioneered the production, but they developed these cells called hybridomas, which are a fusion of lymphocytes and myelomas. These two together become hybridomas, and they make a lot of these monoclonal antibodies. So you can just grow these in culture, large vats of them, and they just pump out a bunch of the exact antibody that you want. And this led to the development of this thing called rituximab. And the funny thing is, you'll notice that all these monoclonal antibodies, their name ends in mab, which means monoclonal antibody. So rituximab. This binds CD40. These are cell surface proteins on the cell. They're just, they're just numbered CD1, CD2, CD3. They just go up to, I don't know what they go up to, but they go up into the hundreds. But CD20 is a protein on the surface of immature B cells, and this was used to treat non-Hodgkin's lymphoma. So this is a drug that's still used today. And in head and neck cancer, there is a drug called cetuximab, or the trade name is Erbitux, and this is a monoclonal antibody against EGFR, which is the epidermal derived growth factor. So that's a similar target. There's another one called trastuzumab or Herceptin. This is a monoclonal antibody that is also an anti-growth factor. So this is similar to cetuximab. But the ones that we're really interested in are these new things called checkpoint molecule inhibitors, or anti-immune checkpoint molecules. So there's a molecule called CTLA4, and they found an antibody against that, the CTLA4 blocking antibody. So this molecule basically modulates the immune system and keeps it kind of at bay, it's kind of like the brakes of the immune system. And so if you block it, you're just like taking off the brakes, and the immune system can get really revved up. And then the first CTLA4 blocking antibody was called ipilimumab in 2011, and they would use this to treat melanoma. And then there's another checkpoint inhibitor called PD-1, or a programmed death molecule, PD-1. And then there's a PD-1 ligand right here, PD-1 ligand 1 and 2. And this PD-1 molecule inhibitor was called nivolumab. And so that's another one for treating melanoma. So melanoma and renal cell carcinoma are two cancers that are known to be pretty immunogenic. The immune system has a fairly easy time recognizing and finding these. So if you just amp up the immune system a little bit, renal cell carcinoma and melanoma can be attacked by the immune system fairly well. Other tumors aren't as good as immune targets. And there's the other drug is called pembrolizumab. These are hard to pronounce. This one is called Keytruda. This is the one that is used in head and neck cancer and has been approved. But all these molecules, the pembrolizumab, the nivolumab, the ipilimumab, these are all checkpoint molecule inhibitors. So these are molecules that are meant to be the brakes of the immune system, and these monoclonal antibodies basically bind them and make them not work, so that you're taking the brakes off the immune system. Which, as you can imagine, there's a reason that we have brakes on the immune system. Because a runaway immune system can cause autoimmune disease and can cause damage to yourself. So these treatments are not benign. They can cause some serious side effects, but they when they are effective against the cancer, they work very well. We'll just briefly touch on these. These are interleukin-2 and interferons. Interferons were one of the first um, cytokines that were identified, and it found that if you treated cancer cells with interferon, this made um, cancer cells regress because they would be attacked by the immune system. So interferons are kind of an immune system activator, and so is interleukin-2. And briefly touch on cancer vaccines because I think this is something that's very interesting. Now, the mRNA vaccines that have been developed for COVID, which by a company called Moderna, which is an American company, and there's another company um, called, wow, I'm totally blanking on the name now, Pfizer and Bio. Okay, anyway, they're a German company that Pfizer teamed up with to create the vaccine. These are the two mRNA vaccines, and those two companies are actually cancer therapy companies, and they had been developing their technology actually as a way of developing cancer vaccines and cancer treatments. But then they noticed that their technology platform could transition well to also make viral vaccines. And the advantage of the mRNA vaccine is that theoretically, if you could use next generation sequencing to sequence cancers tumors individually in a patient, and you could make a mRNA vaccine that's tailored to the exact patient's tumor, because there is you could rapidly sequence and rapidly develop these mRNAs, and I think that is still their plan. And so this could be a way that we treat cancer within the next decade or so, is by taking tumor samples, doing rapid sequencing of it, and then generating a vaccine, an mRNA vaccine that would help your immune system identify your exact tumor. So yeah, so there's been a ton of work. This is a very large area um, of research with thousands of scientists working on it. And in the past decade, there's been this rapid growth in use of checkpoint inhibitors like Keytruda and Ipi and nivolumab that has been very successful in a small minority of patients. The things that we don't know exactly are like which patients will benefit from it. We can't predict who they are very well at this time, and why are some people resistant to it? How does the immune system recognize tumors? How do tumors escape the immune system? It's such a large, complicated topic. But I think there's been a ton of progress in the past several decades. So that's very encouraging. But I hope that this, quick overview of the history of cancer immunotherapy was useful for people that are trying to understand what is immunotherapy and what are these things that are being recommended to me and how do they work, kind of. Okay, thanks for watching, and if you have any questions, comment below.